Secondary hyperparathyroidism, abbreviated SHPT, in chronic kidney disease, abbreviated CKD, is a condition where the parathyroid glands make too much parathyroid hormone, abbreviated PTH. The kidneys are not able to keep normal levels of calcium, phosphate, and vitamin D. So the body tries to fix the imbalance by overactivating the parathyroids. Think of it like a thermostat that keeps turning the heater up because it thinks the room is too cold, even though the problem is a broken window, not the heater. The main causes of SHPT and CKD are low calcium levels. Failing kidneys cannot convert vitamin D to its active form, so less calcium is absorbed from food. High phosphate levels. Damaged kidneys cannot get rid of phosphate, and excess phosphate pulls calcium out of the blood. Low active vitamin D, calcitriol. Without enough calcitriol, the gut absorbs less calcium, and the parathyroids receive a false signal that calcium is low. These three factors act together like a tug of war that constantly pulls the parathyroid glands to release more PTH. People with CKD-related SHPT may notice bone pain or tenderness, especially in the hips, ribs, or fingers, muscle weakness or feeling tired, itchy skin, pruritus caused by high phosphate, frequent fractures or a loss of height over time, sometimes a feeling of pins and needles in the hands and feet. An easy way to remember is to think of the skeleton as a house. When the foundation, bones, is weak, you feel creaks and cracks everywhere. Diagnosis: blood tests that show high PTH, low calcium, high phosphate, and low calcitriol. X-rays or bone scans to look for bone changes. Renal osteodystrophy. Kidney function tests (e.g., to confirm CKD state. Treatment: Number 1, phosphate binders. Chewable tablets taken with meals that trap phosphate in the gut so it isn't absorbed. Number 2, vitamin D analogs, calcitriol or alpha-calcidol. Give the body the active form of vitamin D it can't make. Number 3, calcimimetics, cinacalcet, medicines that make the parathyroid glands think calcium is higher, so they lower PTH. Number 4, in severe cases, surgical removal of part of the parathyroid glands, parathyroidectomy, may be needed. A practical tip: ask patients to pretend they are a chef. They should take phosphate binders like a spice added to every meal, and check their ingredients, lab values regularly. Prevention focuses on keeping the 3 biochemical triggers in balance early in chronic kidney disease. Control phosphate intake by choosing low-phosphate foods, fresh fruits, vegetables, and avoiding processed meats, cola, and cheese. Take prescribed phosphate binders with every meal. Get enough active vitamin D, either through supplementation or sunlight exposure, but under doctor guidance. Monitor blood tests every 3 to 6 months, so any rise in PTH can be caught early. Think of it as regular car maintenance, changing the oil phosphate binders and checking the fuel gauge vitamin D prevents the engine parathyroids from overheating. Newer non-calcium-based phosphate binders, for example sucrophoric oxyhydroxide, that cause fewer side effects like constipation. Extended-release calcimimetic pills that can be taken once daily, improving adherence. Early-stage clinical trials of monoclonal antibodies that target the PTH receptor, showing promise in reducing PTH without causing low calcium. Use of wearable sensors that continuously monitor serum calcium and phosphate trends, allowing doctors to adjust medications in